Everybody, and welcome. Today, I'm really excited to share this video with you. I'm with Dr. Mandi Murtaugh, a colleague who I really respect. She is board certified clinical specialist in women's health, and she is a pelvic physical therapist. That is her specialty. And it's really important to me that I talk to people who are experts in their field when we're talking about really specific issues on how we exercise for our bone health. So, Dr. Mandi, thank you so much for joining me today. Mm-hmm. One of the questions that I get very frequently, because impact exercise is an integral part of what we want to try to do for bone health. So that could be heel drops, jumps, jumping jacks, box jumps. It's also step ups. So we have a lot of variety on how we do that, but some of those things might not be appropriate. What is pelvic prolapse, and how does that impact someone's ability to do those exercises?
Beautiful question, and a question that I get all the time in the clinic too. I like to joke that I can cure a prolapse 50% in one visit just by educating somebody about what it is.
That's no joke. That's
it's
fantastic.
Huge. It's huge because it's the big thing to understand about a prolapse is that how much it bothers you is the most important thing. And so most of it's kind of shrouded in mystery, or the story is that something's falling out of your vagina. And to understand that that's not actually true helps to just relieve the concern over it.
That could be an interesting vision for someone to think about their body, right?
Yeah,
very concerning if that's how you
Absolutely.
see it. Absolutely. Right.
And that's what people, I just had somebody who's just postpartum and mentioned that I said she has a prolapse, and a friend says, it's a big deal that something's falling out your vagina. Yeah. Like, it's not. There's nothing falling out your vagina.
Okay.
So
I've learned this already.
And this is, this can happen at various stages of life. And oftentimes even, it happens most typically in people who have had babies, but also doesn't have to be. The biggest risk factors are pregnancy and vaginal births. Also lifelong constipation. So even if you've never had a baby but have had constipation or a lot of downward pressure, then that can impact it and cause it. So what exactly is it? Go through a quick pelvic floor anatomy review. Here's your pelvis and your spine. Your uterus, if you still have one, sits right on top of the bladder, and then the rectum sits in the back. Basic pelvic floor anatomy, there's 3 layers of muscle. The most superficial layer is largely for sexual function. There's a middle layer that's largely for urinary function and for sphincter control. So it helps us control our urine, control our gas. And then there's a deeper level in here that is really about supporting the organs. And so a prolapse is when part of that support is a little bit lacking, is for lack of a better term. So if we take all these out, and of course these are models, this is not a real human body, but generally what it looks like is the vagina is here in the middle between the rectum and the bladder. And so what a prolapse is when one of these organs pushes against the vaginal wall. The vagina is empty if nothing's in it, right? We often think of it like a tube, but in reality, it's just a bladder sitting against a wall, sitting against the rectum. So prolapse is when either the bladder pushes against the vaginal wall, or the rectum pushes against the vaginal wall, or sometimes the uterus itself comes down.
Okay.
So when it's the bladder or the rectum, I just like to reassure people they can't fall out. There's a vagina there, right? So they can't fall out. I've heard it said, like, if you're sitting in a tent, if you're in a tent and your friend is walking around outside the tent and they trip and they fall on top of you, they didn't fall into the tent, right? They fell against the wall, but they fell on top of you. And that's kind of what's happening with a prolapse. Primary symptoms of prolapse would be pelvic heaviness. Sometimes it feels like a tampon is stuck, is what I'll hear from people. In more extreme cases, it feels like I'm sitting on a golf ball. Oftentimes it happens at the end of the day, or as the day goes on, or after a workout. So that's the first thing that I would encourage your listeners to be aware of is, at the end of a workout, do you feel heavy, or do you feel like there's something in your pelvic floor? Does it feel like there's something that's kind of falling out?
So that's a real key with that self-awareness and that tuning in, that mindfulness of how your body feels after exercise, and paying attention to those symptoms. So feeling of heaviness or pressure or a golf ball. Okay, those are great cues for them to pay attention to.
Yep. Great things to pay attention to. One of the cool things about prolapse is that there's it's a very subjective experience. And so it's not a medical concern. There's not risks of, unless the prolapse is actually extreme enough that it's like the vaginal walls rubbing on your underwear and causing abrasion, which is again, more extreme cases. It's not a problem unless it's a problem to you, if that makes sense.
So there isn't an inherent danger or increased risk for someone who has that, unless they're feeling that it's not comfortable for them.
Exactly. So the degree of bother is the problem with prolapse.
Got it.
So I've met people who have a grade 2 or grade 3 prolapse, and they're just graded on grade 1, grade 2, grade 3. Details I don't need to get into.
Sure.
But they might have a more severe prolapse on assessment, but it doesn't bother them. Or I've had people where I'm like, your symptoms sound like a prolapse. I don't actually see one when I test you, and your doctor doesn't see one, but it's really bothersome to them.
Sure.
So it's all a subjective experience.
Sure. Okay. So you treat the person.
I treat the person.
Yes.
I treat the person. And I love seeing people, quite often the people who are referring folks to us, to pelvic floor PT for prolapse, are surgeons. So a lot of people out here, and this is where I love education like you're providing, is that people go to their doctor and they get referred to a surgeon, and they're on a wait list for weeks, and they're bothered by these symptoms. And then once they get to that level of referrals, then their doctor says, well, go see a PT. So a lot of us are self-educating these days, learning more on YouTube from great resources like you, that if you're feeling these symptoms, you can go and see somebody while you wait or before you pursue that. So the degree of bother is the important thing to look for.
Wow. And certainly if the surgeon is the first step in the referral process, how does that affect the level of anxiety and concern when somebody could perhaps see a pelvic specialist physical therapist first and get a better understanding of what's happening?
Yep.
Wow.
And that's my hope even through this, is that just understanding a little bit more what's going on helps to calm some of the anxiety, calm some of the worry, so that you can do what you want to do.
Excellent. Are there treatments, are there specific exercises that you feel are helpful for someone that has this?
The main things when we're treating prolapse is we're looking for how strong is your pelvic floor, and that's more than just teaching Kegels. So it's a bit more complex than that, but how strong is your pelvic floor? What is your posture like, and what is your breath doing?
Talk to me about posture. Why is posture important in that?
Prolapse is a pressure problem. Say that 5 times fast.
Oh, I love it. Prolapse is a pressure problem.
So if you think of, I mentioned constipation earlier. The trouble with constipation is if for a lifetime you've been
bearing down,
holding your breath, bearing down.
Right.
Then that's what is pushing. Pressure finds the path of least resistance. And so if, say, the pelvic floor is tight and that anal sphincter is tight and you're bearing down, then the path of least resistance might be that wall between the rectum and the vagina. And so then we end up, that's called a rectocele. Or from the front, that path of least resistance might be between the bladder and the vagina, which would be a cystocele.
Okay.
And this is part of why vaginal birth, obviously, can contribute to this as well. So when we are exercising, especially when we're doing impact, doing any exercise, if we are in a posture that is putting excess pressure on a less supported part of the pelvic floor, then that can decrease the amount of support. So if we come back to this anatomy model, those of us born in female bodies, we have kind of one less layer of support right here, which is why a baby can pass through there if that's our course in life, because all of this stretches, right? And if you look from here, you can see we've got this triangle of superficial support, but that's not back here. So if you imagine that you're sitting like this a lot, or you're doing a box jump like this, now all of your organs are kind of being pressed back here.
So you're talking about being in a more kind of posterior pelvic tilt, tucked under, rounded posture is going to place more pressure than if we are more vertical with a neutral pelvic position, so we can rely on the structure to do what it's designed to do.
Exactly. So we've got a little bit of our passive support. So that's always my first thing I'm looking at. Can I go ahead and stand up and show?
Absolutely. Yeah. So position is where we start.
So if I see somebody who's doing this, say we're doing jumping jacks, and here we're jumping, And A, I might feel more heaviness, and B, I might be leaking. Because we didn't talk about that, but prolapse can oftentimes lead to stress incontinence, which is leaking with coughing, sneezing, jumping. And so if we're really tucked under, then we have a funky position with our ribs. We also have our diaphragm. Our diaphragm and our pelvic floor are like a piston. So they both, when we inhale, our diaphragm drops down, our pelvic floor drops down, and we exhale, they come back up. But if I'm here like this, then they're kind of at this funky angle.
Right.
Same thing, if I'm really like this, then they're also at this funky angle.
So too much arch, too much tilt. Right.
Yep, so this is where that neutral spine really comes in. So if I'm trying to jump like this, then A, I'm probably landing more on my heels, which is putting more force through, and my pelvic floor is not at a great position.
And it's also not an ideal position for bone health either,
not
right?
good, period.
So we don't want to have too much spinal flexion when it comes to doing exercises for bone health either.
Yep.
So that ideal posture works across the board here.
Exactly. And so if we can get ourselves into this pelvic tilt that's neutral, now our diaphragm and our pelvic floor are in line with each other, and then we could do activities. With that little bit of, oftentimes I'll be treating somebody who's a runner and they say, I don't leak when I'm going uphill, or I don't feel that heaviness going uphill, but I feel it going downhill. And that's part of that too, because going downhill, we're kind of in this open position.
Right.
And going uphill, we have a little bit more of that force forward.
Where there's more stability.
Yep. So that's where posture comes in, of just saying, can I have even a little bit of, we call it the ski jumper. So a little bit of that pressure forward. And this is a great example or a great test if you, like jumping rope, for example. If you're leaking with jumping rope or feeling really heavy, then it can just be, can I kind of get forward here? So I've got a little bit more forward movement. And then I'm here on that, almost on the pubic bone.
Sure.
Is really what's happening.
So make a micro adjustment in your posture and reassess.
Yep.
And these small changes in tuning in to how our position is and then reassess our symptoms can be how we find that sweet spot of a solution.
Yep.
It doesn't have to be huge. It doesn't have to be dynamic. It doesn't have to mean we eliminate an exercise.
Yes.
But we can make micro adjustments to see how we do that.
Yep.
So I love that. So when just looking at something like jumping rope or jumping jacks or just heel drops or just small like pogos or something like that, you can just make these tiny adjustments, and your cue is to be a little more forward than back. Right. I love that.
Yep.
Okay. Super.
One of the trainers that I have learned from uses the cues that shouldn't be too, it's not vulgar, but uses the cue tits over toes. That's a good cue of just like a little bit of that forward movement.
Gotcha. Okay. Just feeling where that presence is not back on your heels.
Exactly.
And not kind of open in the abdomen,
Yes.
but just having that strong kind of pillar, right? We want that pillar of support.
Exactly. And I'm always, I always call myself an inside out PT. So I'm looking at this deep core first. Usually when we think of core, we think, sit-ups and planks and these big activities. But when we think of the deeper core, the pelvic floor is the base of it. The transverse abdominis is the front of it. Our diaphragm is the top, and then our back muscles are back here. And you just said pillar, right? I always talk about like a canister.
Exactly.
And all of these muscles have to activate first before we jump, before we run, before we move. And that's where our stability comes in.
Okay. So you feel, or do you feel that if somebody is working at this slow process, is jumping in the realm of possibility for some of these women?
Absolutely.
Okay.
Absolutely. So what I would recommend is if you, and I'm going to come back to leakage a little bit.
Sure, absolutely.
Because I think that's the easiest.
Together.
Yeah, that's the easiest, test A, test B sort of a symptom.
Right, self-assess, yes.
Yeah, like I always will tell people, go do a jump rope test. Just go and like, how many jumps can you do before you start leaking? And then you can adjust your posture, or you can adjust over time how that changes.
They can work into jumping, and
Yes.
is it reasonable for them to work up to that?
Yep. Again, part of what we come back to is your severity of symptoms. How much do your symptoms bother you? First of all, I am a big fan of pad up and play on. So if you're afraid to go jump because you're afraid to leak, put on a panty liner. If it's keeping you from doing what you want to do, there's no shame in a panty liner. There's no shame in a pad. And let's work on it. It's not an answer. It's not a solution.
Right.
But let's keep you, especially if we're weighing bone health versus a tiny bit of incontinence or some level of bother, let's put a pad on so we can work on our bone health, and then let's work on our pelvic floor in the meantime.
I love that. I love that. Instead of saying, don't do this exercise for the rest of your life, let's find a way to make it possible, because we can help educate that this isn't danger, not causing danger, but we can help you be more comfortable and feel conscientious about what's happening. So putting a pad on if there's leakage, but still able to do the exercise that somebody wants to do for the other part of their health.
Exactly.
Which is all of them.
Exactly.
Right?
Exactly.
I love that.
Yep.
And it's not either or, and work with a specialist to help create improvement in that area.
Absolutely.
Love it.
Absolutely.
Love it.
Yep. Even folks, there's been so many studies done of do people do a Kegel or a pelvic floor contraction, right? And when they've only been verbally taught how to do it, all of us were told by our doctors at some point, right?
Yes,
Just go do Kegels.
Yes.
And only about 40% of women do them correctly. And that's part of what we assess. And again, I of course think everybody should go see a pelvic floor PT. Does everybody need to? There's a lot of people who are fine without it. But if you're having these symptoms, it's invaluable, because what we do is an internal assessment to make sure that you're actually activating your pelvic floor correctly.
Okay, wonderful.
Now, when we come back to jumping, so say we're symptomatic with jumping, but we really want to jump. I like to break it down to the basics of, let's look at your posture. Let's look at your breath.
Love it.
So again, we talked about kind of this canister that when we breathe in, our pelvic floor actually drops or relaxes. And when we breathe out, it comes up. I did. I saw that. Everybody at home did too.
Of course.
So ideally, we have this contraction or this lifting, gathering of the pelvic floor with an exhale. Now, I want to name, if you're trying that at home, a lot of people want to squeeze on an inhale.
Oh,
It's probably 50-50 of people I work with. My theory is that we learned to suck it in early on. So when we're thinking of, oftentimes people with stress incontinence are leaking with coughing, sneezing, jumping. These are all usually exhales. When it comes to prolapse and that pressure system, if we're going and holding our breath as we jump, that pressure, again, is going to find the path of least resistance. So say we hold our breath, we do a jump, and we have that force from the ground coming up our body. If our pelvic floor is that path of least resistance, then that prolapse is going to be heavier, or we might leak.
So the breathing needs to be specific for people concerned about prolapse and how they support their pelvic floor. So how do you teach this?
Very carefully sometimes.
Very carefully, it's tricky, right?
It's so interesting. And people have a lot of feelings about, like, shouldn't I know how to breathe? I just had somebody yesterday. Like, I feel embarrassed that I have to learn how to breathe again.
I don't think about it. It just happens.
Exactly. And there's so many things in life that we hold our breath for in different ways.
But the cool thing about our breath, I actually find it fascinating, is it's both automatic and we can take deliberate control over it. It's like, to me, that's just absolutely magical.
It's fascinating. It is. So number one thing is avoid holding your breath.
Okay.
Especially, I know that you're teaching people to lift heavy. Right? So especially when we're lifting heavy, avoiding like, as I'm doing another rep.
And that's taught a lot with some of the heavy lifting to create that column of pressure, but it's different when you're talking about somebody with a prolapse.
It's different.
We don't want that pressure to go to that weak point.
Exactly. And there we're looking at goals. Right? If your goal is to have a 1 rep max in a competition, by all means. It's a different story. I'm guessing most of the people who are following you are not
No, we don't even encourage 1 rep max for people with low bone density. We don't do 1 rep max testing, and I don't encourage people to do 1 rep max because it just isn't a reasonable thing to ask your body to do. 5 rep max,
especially maybe. in this phase, right? If our goal is let's build some bone density, let's stay healthy,
avoid falls, let's become fracture proof, but we don't need to be going for that. As that's not the primary goal of most of my followers.
So when I learned weightlifting back in, 6th grade, exhale with the effort. That was always a thing, right? We hear that in PT all the time. So exhale with the effort. So number one, just avoid holding your breath. If you can't do a rep of something without holding your breath, you probably need to lighten up. So a little bit less. So not holding your breath and then exhaling with the effort. So that's where we start.
Okay. So it would be a nice inhale. And then as you're getting ready to do the jump, we're doing an exhale.
Yep. We're squeezing our pelvic floor and we're doing an exhale.
Describe that
And
for
this
us.
is where it gets complicated.
Okay.
Yep. So this is where sometimes I just say, let's really break it down. So even as we're sitting here, you can think of inhaling to prepare. And then as you exhale, you're just squeezing up and in. And this is squeezing like you're going to stop urine, like you're going to hold back gas. And you should be able to feel that with an exhale. As you inhale, you can release it. As you exhale, you're squeezing it in.
So as you inhale, it naturally wants to release. It naturally wants to drop down.
Yep.
So if we're not kind of trying to force anything there, that just feels really natural. So inhale, pelvic floor kind of drops down. Exhale, we squeeze up and in as you're doing your effort.
Yep.
Love that cue.
And I would say start this. Some people, this is going to be like patting their head and rubbing their belly.
It would be for me.
Really uncoordinated.
Yes.
Yeah. So we start with like, okay, let me just try this in sitting. Sometimes let me try this in laying down. Because if we're laying down, gravity is not on our pelvic floor, right? I do find, however, in people with prolapse, oftentimes sitting, they feel more connection to their pelvic floor.
Yes.
Because they're lifting against something, right?
Yes.
They're lifting up against that prolapse.
You feel it moving towards or away.
Yep. And as soon as you stand up, it's going to feel different.
Yeah.
Because then we're adding everything else. The other thing with this isolated, and again, this is just really picking it down, saying, okay, let's do some isolated pelvic floor contractions or Kegels with my breath to kind of do this motor programming, sort of.
Make it become
before
automatic.
we add the complexity.
Yes.
Exactly.
Yes.
Because if we're in here trying to say, okay, do a Kegel with every rep,
Right.
our brains are going to explode.
Right.
But if we can teach, okay, a pelvic floor contraction comes with an exhale, then all you have to do is focus on the exhale when you're at the gym.
And what comes to mind for me with this is we have to slow down.
Slow down.
We have to take our time to learn these steps and processes. I see a lot of people and they're in a rush. They're doing their reps. They're getting up. Let's slow it down. Let's do it right. Let's feel it in our body and get these precursors, get this foundation built before we're trying to do the more complex movement. I love how you talked about that. So I'm going to stand here. We'll talk about one exercise. So one exercise we do is called heel drops. So that's rising up on the toes and letting the heels come down with impact. And so there's going to be that force on the pelvic floor in a downward manner. So a strategy, we'll kind of talk through this together. A strategy would be to inhale, exhale, while I'm contracting the pelvic floor. Right. So that exhale happens on the way down as I'm getting ready for the impact. And I feel that. I feel that tension as I hit. That felt like support, like that hammock tightened up a little bit.
Beautiful.
That was
beautiful.
That's perfect. I hope that's helpful.
I'm glad you said hammock too. I often will describe it as a hammock that's holding up these organs.
Yeah, and it just felt like that hammock just had a little more kind of firmness to it as my heels hit the ground. And I totally felt that. So practice this. That'll be a great thing for people to practice when we're talking about heel drops, which are a very evidence-based and effective method for bone density. And you don't need to do thousands of them. You can start with 10 per day.
I've started doing them at the bus stop.
I love
ever
it.
since I heard you say that.
I love it. That's wonderful. Boy, that was a great cue. I totally felt that. And so this is exciting for me. I'm learning this too as you're sharing with us. I so appreciate this, that is still something that women who experience prolapse can do, working through these techniques, working on their posture and position, working on their breath, and contracting their pelvic floor. In the right order. Slow it down. Break
slow it down. Even when we're talking about this local core again, that the local core, that deeper core really activates with coordinating with the breath, slow movement, low load. So oftentimes body weight is plenty, and then lots of feedback. So it can even be, okay, having my hands on my belly. If you're doing that pelvic floor contraction, you'll often find your deep tummy kicking in too. Not like a whole, but that pelvic floor and the TA, the transverse abdominis, will kick in together.
Absolutely. I mean, these things work as a system, right?
They do, and they're preemptive.
Yes.
I'm glad you said precursor too. They really are. They need to activate before the big muscles move.
There we go. There we go. Okay. So I love that I can share with my listeners that heel drops are a great place for them to start. The other exercise I love that doesn't involve a lot of kind of bang or impact as we think of it. And I share impact as a term of multiples of body weight. It's those multiples of our body weight force on our skeleton is what's encouraging the bone to become stronger and adapt. We can do that without having to jump by doing a step up. And coordinating the breath with a step up could happen. So like a 6-inch step up could be more than 2 times body weight. A 12-inch step up would be closer to 3 times body weight. So we're really able to increase that load. Then you put a couple dumbbells in your hand, and we're really accomplishing what we want to accomplish without it having to be jarring, so to speak. So if people don't feel comfortable doing box jumps, they can do that. But the same principles apply if they're holding weight, which adds pressure, going up and down a step. They still need to take their time with their posture and their breath and that pelvic floor contraction.
Yep. And I think a step up is a beautiful example of that because you're automatically getting that forward movement.
Love it.
And just slowing it down and saying, I'm going to, you might put your foot on the step, take a breath in, prepare, engage your pelvic floor, and then step forward.
Love it. Love it.
That's a perfect example.
Wonderful. So this is so encouraging for women that are experiencing prolapse and or some stress incontinence, that there are ways to adapt, and working with a professional in pelvic health can make a huge difference in changing their symptoms. I know this is what you do all day in our Tacoma community at Thresholds Collective. And you see the change that they can experience, right?
I do. Yeah, it's amazing.
To me, it's so important that people have that hopefulness that there can be support, there can be an answer, there can be ways to feel more confident in your body. Is there anything else you would like to share with the listeners about this topic today?
Yeah. There's 2 more things. One is that there is help if you try all of these things and they aren't helping, that there's excuse me, a next level of support that's actually putting support inside your vagina if you're comfortable with that. If you went to a physician, you'd get a pessary, which is silicone ring, but there's some over-the-counter options too. And I even encourage people, if you still have a tampon laying around, I know a lot of your folks are probably not bleeding anymore, but there might be one in a drawer, to even just put that in and see, okay, do I feel better if I have something inside the vagina supporting?
It's kind of a space-occupying support.
Exactly. Yep, exactly. And there's some over-the-counter options, and I can share you links if that would be helpful for folks. Getting anti-gravity. That's what it is. So if you know you have a prolapse, if you did a workout, finish that workout lying down. Do some child's pose, some happy baby, legs up the wall.
Change the orientation of the system. Yes.
Exactly, because again, prolapse is a pressure system and we live in gravity. And so it might be that you're interspersing your workouts even of doing some weighted bridges. I love bridges with prolapse.
Yes,
right?
Bridges is a great exercise for prolapse. There's another tip here.
So big. Yep.
Very
even
good.
if you want to put some weights on your belly or a medicine ball or something so that you're still getting increased weight, but you're in this anti-gravity posture. I
love it.
And just interspersing that or finishing the workout, laying down for 10 minutes. Because there are ligaments that are holding your organs, right? We sometimes just think the pelvic floor is holding everything up, and that's not true. It's doing part of it. But there's ligaments from the uterus. In fact, the topmost layer of support at of the pelvic floor is at the cervix.
We have these sling systems all over, don't we?
Yes, we do. Yeah. So, and all of our tissue, it creeps, right? It creeps with gravity.
I know it. Yes, it does.
So the same thing happens with the pelvic floor.
Yes.
So if we can unweight it, give it a break throughout the day, then doesn't undo it, but it, by the end of the day, I always think of like a penny being hung from a rubber band.
Yeah.
That by the end of the day, even if it's not much weight, it still is longer.
Right.
But if we unweight it throughout the day.
Yes, we can let that elasticity kind of come back into a shortened position and let the system sort of rest a little bit even.
Yes.
Yeah.
Exactly.
Take that pressure off.
Exactly.
This has been so incredibly valuable. I've learned a ton because this is not my area of specialty. I so appreciate your time in sharing this. I know it's going to be very, very valuable to so many people to figure out how they can continue to do exercise for their bone health and feel like they're not causing any damage in the process.
Yes.
Thank you so much.
Absolutely.
All right. If anybody wants to work with a pelvic health specialist in the Tacoma, South Puget Sound area, here's your person. Thank you so much.